Good afternoon. Today, we're going to walk through a proactive approach for your VA patients. Our goal is to help them navigate the VA healthcare system and get them back to you, a community care network provider for oral appliance therapy. This program was developed by Dr. Martin Denbar and Eric Northey at Texas Dental Sleep Services, and everything we cover today is designed to be immediately actionable in your practice. Our objectives today are threefold. First, we'll help you understand the VA Community Care Network ecosystem and the specific access standards that trigger a veteran's eligibility to navigate back to you. Second, execute. We'll show you how to complete part of the VA request for service from and build a clinical support packet that minimizes friction for the VA provider. Third, advocate. We'll deploy a two-pronged approach and introduce digital escalation protocols to secure authorizations. By the end of this presentation, you'll have the tools, the language, and the process to drive VA referrals proactively.
As we all know, sleep apnea is a silent epidemic, and it has an even higher prevalence among veterans. The silent battle, veterans suffer disproportionately high rates of obstructive sleep apnea. Many suffer from CPAP intolerance, never received a CPAP, or simply do not use the one they were given. Left untreated, OSA leads to severe consequences, cardiovascular disease, cognitive decline, depression, and more. Together, we offer the solution: oral appliance therapy. The VA and DoD clinical practice guidelines recognize oral appliance therapy as a first-line therapy for mild to moderate obstructive sleep apnea. It is preferred by patients and ideal for those who suffer from PTSD, anxiety, or travel frequently. And here's the critical distinction. Oral appliance therapy is classified as a medical benefit, not a dental benefit.
Let's put this side by side. CPAP has high abandonment rates, triggers claustrophobia and PTSD responses, and is cumbersome for travel. Oral appliance therapy, by contrast, is recognized as a first-line therapy under the 2025 guidelines. It's a medical benefit with broad coverage, and it has significantly higher compliance rates. Most people are not compliant with CPAP, and many more simply don't seek treatment at all because they think CPAP is their only option. That's the gap we're filling. This is the core philosophy of the program. We don't wait for referrals, we drive them. The passive approach was to simply hope the VA refers patients to you. That may or may not happen. Our approach is proactive, breaks that cycle. We educate the veteran, provide them with a pre-built referral packet, teach them to drive the referral themselves, and follow through until they receive the treatment they deserve. These may already be patients in your dental practice, or they may be veterans you've engaged through marketing or community outreach. Either way, this program shows you how to help ensure they return to your practice for treatment.
The process starts with the initial consultation. The golden rule: no billing to the VA without prior authorization. This is an informational and screening visit only. The goal is to gather the data you need to build the case for referral. If these are patients already in your dental practice, this consultation can be conducted alongside a hygiene visit. It's complimentary. If these are new patients who came through your marketing efforts or referrals, the consultation becomes a critical rapport-building opportunity. Important: you cannot bill the VA or commercial carriers for this consultation. However, you can bill the patient directly, and you may or may not decide to credit that amount if they proceed with treatment. During the consultation, you'll work through 4 steps. First, verify their status, confirm whether they've already been diagnosed with obstructive sleep apnea. Second, check their history, document whether they've received a CPAP and whether they are intolerant to it. Third, educate, explain the risks of untreated OSA and the benefits of oral appliance therapy. Make sure they understand that OAT is a covered VA medical benefit. Fourth, and most important, empower them. Tell them you have the right to request this care. Share their rights as a veteran and explain how to navigate the VA healthcare system to get back to your practice for treatment.
It's important to set expectations up front. If all goes well, the referral process typically takes 2 to 4 weeks. The veteran must discuss this with their VA primary care provider at their next visit. And there are no guarantees. We facilitate the process, but the VA must ultimately authorize the referral. If the process goes smoothly, they could be back in your chair for treatment within a month. If they encounter obstacles, this program gives you and the veteran the tools to navigate around them what to say, and who to say it to. Let's talk about the key players. At the top is the VA Medical Center. This is where decisions and authorizations are made. In the middle is the primary care provider, usually the person who initiates the referral. At the bottom is the community care office. They facilitate the approved referral. Our goal in this program is simple: make the PCP's life easy and the community care office's job seamless. When we do the administrative work for them, the referral moves faster.
The most important person in this entire process is the veteran. They are their own primary advocate. The veteran is the requester. Only they can initiate the request during a visit with their PCP. They must state their preference, specifically asking for your practice by name. They must articulate the why, that they are CPAP intolerant, clearly and confidently. Coach them on this script. I cannot use my CPAP. I want a referral to TDSS for an oral appliance. Simple, direct, effective. They need to know how to express their intolerance, and they need to understand the 28-day and 60-minute access standards we'll discuss in a moment. The veteran's spouse can also be a powerful advocate. Often the spouse is also suffering from the snoring and the disrupted sleep. Shift the narrative from my sleep problem to our health issue. The spouse can also help drive the process by making phone calls the veteran may not be able to make. Beyond the spouse, there are veteran support groups, organizations like the VFW and the American Legion, and others that can assist. The veteran must initiate that process, but with strong support, they can make sure they get the treatment they deserve from the provider they prefer.
Now let's talk about the legal foundation, the Mission Act. The Mission Act is an important document because it points out that Congress passed laws securing the veteran's the right to be seen in a timely manner and by their preferred provider. The Mission Act outlines the consolidated community care programs and veterans' right to seek treatment from community care network providers like you. The key takeaway: eligibility is based on specific access standards. Review and become familiar with the Mission Act. It's your roadmap. The access standards are straightforward and they are virtually never met by the VA healthcare system. 28 days. If the wait time for a specialty appointment exceeds 28 days, the veteran is eligible for community care. 60 minutes. If the drive time to a VA facility offering the service exceeds 60 minutes, the veteran is eligible. If either of these standards is triggered, the veteran has a right to request a referral to a community care network provider. The result is automatic eligibility. Even if the 28-day and 60-minute standards don't trigger eligibility, there's another pathway. The best medical interest exception allows eligibility when the clinician and the veteran agree it is in the patient's best interest. Examples include mobility issues, severe anxiety or PTSD, or an established relationship with a local provider. This is important to know. It means there are multiple avenues to eligibility, not just the access standards.
Here's where we reduce the friction. As a contracted CCN provider, you can do much of the administrative work for the PCP. We will prepare a clinical support packet for the veteran. Please note, we are moving away from the term weapon. But this packet is powerful. It contains 3 components: a professional cover letter, a pre-populated VA request for services form, and any supporting documentation, such as sleep study results and CPAP intolerance notes. The objective is simple: do the administrative work for the VA PCP so they have no reason to hesitate. The cover letter serves as a professional introduction between your practice and the PCP. It should include the patient's name and date of birth, a brief clinical summary covering the obstructive sleep apnea diagnosis and CPAP failure, and a specific request: referral to TDSS for oral appliance therapy. The tone must be respectful, medical, and collaborative. This is colleague-to-colleague communication. Reference the attached request for services form and ask the PCP to complete Section 2, Field 19 through 22, then submit it to the VA Medical Center or Community Care Office. Note that the PCP could also initiate the referral through HSRM, though some PCPs are not familiar with that system. When completing the request for services form, pre-fill the veteran's demographics in Section 1 and the diagnosis and treatment details in Section 2, stopping at Field 18. Please note there is no Section 3. Critical rule: never complete fields 19 through 22 and never sign the form. These fields are reserved for the ordering VA provider only. If you complete or sign those fields, you risk invalidating the entire request. Your job is to make this as easy as possible for the PCP. Fill in everything you can and leave the rest for the PCP.
Field 18, the reason for request, is important. This is where you connect the dots, cite the law, and establish the clinical need. The narrative should read, veteran diagnosed with obstructive sleep apnea with the correct diagnosis code, documented intolerance to CPAP. Veteran requests oral appliance therapy at TDSS, and cite the correct section of the Congressional Federal Registry, the law that secures their rights. This single field accomplishes three things. It connects the diagnosis to the treatment, it cites the specific federal regulation granting the veteran's rights, and it documents the clinical need. When the PCP or community care office reads this, the path forward is clear. Now for the execution, the two-pronged approach. Prong 1, facts. Send the complete packet to the PCP and or the patient-aligned care team 2 to 3 days before the veteran's appointment. Prong 2, hand carry. Give the veteran a physical copy of the same packet and coach them to deliver it in person at their appointment. By creating this redundancy, we eliminate the chance that anyone says the paperwork was lost. The information arrives from two directions, ensuring it reaches the decision maker.
When executing the FACT strategy, target the specific clinic or PACT, their patient-aligned care team, not the general hospital number. Ask the veteran which PACT they are assigned to. Always keep the transmission receipt as confirmation. And timing matters, send the fax 2 to 3 days before the veteran's appointment with the PCP. This gives the provider time to review the packet before the veteran walks in the door. You can also help the veteran use the VA mobile app to initiate or support the request through secure messaging.
When you hand the veteran their packet, coach them on three things. The script. I have a packet from the sleep dentist that explains everything. The action. Hand the packet to the PCP or nurse practitioner at the start of the appointment, not at the end as an afterthought. The backup. If the doctor or nurse hesitates or seems unsure, instruct the veteran to say, please look at Field 18. It explains the reason for the request and cites my rights under federal law. This combination of script, timing, and backup ensures the veteran presents confidently and the provider has everything they need.
This slide contains 9 quick reference flashcards covering the 28-day, 60-minute access standard, the 6-step referral journey, oral appliance therapy as a medical benefit, what the provider can do versus what they cannot do, the important reminder that oral appliance therapy must be ordered by a medical provider, and before you do any treatment, be sure you have the correct authorization, the referral packet checklist, veteran escalation scripts, the escalation pathway and digital tools, and a quick question and answer reference card. These cards can be printed on cardstock, cut out, and kept in the office for quick reference by your staff. They're designed to put the essential information at everyone's fingertips. This final slide maps the entire journey we just described. Phase 1. Start with screening and education, a consult to discuss CPAP intolerance and oral appliance. Then prepare the mission packet. Have the veteran hand carry the packet to the appointment. Use the 28-day, 60-minute safety net if needed. Phase 2. Activate the Advocacy Command Center, the veteran, the spouse, and veteran support groups. Use the VA mobile app and scripts to follow up within 7 days. Secure a medical SEOC, standardized episode of care, referral, and make sure it goes through the medical lane, not the dental lane. That warning is critical. Now that we've completed this presentation, we want to point out the manual titled Proactive Approach for VA Patients, a 40-page companion guide that goes into much greater detail on every step of this process, and the Veteran Care Packet with everything you'll need to implement this program. Good luck with this program, and please feel free to reach out should you have any questions. We're here to support you. Let's get those veterans scheduled.